Ribe. It's for relatives. Very warm good evening to all. Hope I'm properly audible, sir.
Yes.
I'm
Yes.
properly audible, no, sir?
Yes, sir.
Okay, my screen appears enlarged on your screen. My PowerPoint presentation.
Yes, sir.
Yes, fine. So very warm good evening to all. First of all, I'd like to thank the organizers of VISHWA Ayurveda PARISHAD for inviting me for this online lecture. First of all, I'd like to thank my teacher, my mentor, Dr. Professor Santosh Chavan sir, HOD of Panchakarma Bharati Vidyapeeth deemed university for inviting to me this seminar. Also, I'd like to thank the national convener, Professor R.K. Gupta sir, HOD Panchakarma Government Ayurveda College, Jabalpur, and the coordinator, Dr. Chetan Gulhane, a practitioner from Mumbai, and other executive members of VISHWA Ayurveda PARISHAD for inviting me to this lecture. So anyway, we are already late. Can I just go straight into the topic?
Yes.
Okay. So, Rogamada Parikshade Tadanantaram Aushadam. This slogan emphasizes the importance of diagnosis in Ayurvedic clinical practice. So, Rajaryas has mentioned that before starting any treatment, proper diagnosis of the disease has to be made. So, nowadays, the investigations, the era of investigations are made in a quantum jump. If you take a hematological investigation, if you take biochemical investigation, if you take the radiological investigation, the area of investigations are very large. Now it's the need of the hour to understand how to read, interpret the radiological investigations for a proper diagnosis. As you know, patients come to Ayurveda more for an orthopedic treatments. So the orthopedic treatment, the investigations of radiological investigation is inevitable. So we need to have a proper command on the investigations. Then only we could properly diagnose and treat the disease. So today, my topic is the radiological diagnosis of spine disorders and its Panchakarma. Today, I'll be focusing only on the X-rays because the time what you're given is very limited. So in that short span of time, we can't cover other investigations like MRI, CT, etc. So as a basic investigations, I will be focusing on the radiological, that means the X-ray of the spine. So the basic how the X-ray need to be taken, what are the basics of X-ray, which are the views need to be taken, etc. So in this photo, you can see Mr. William Conrad Röntgen. He is considered as the father of diagnostic radiology. He has invented this X-ray in 1895, and he got the Nobel Prize for his invention in 1901. So he is considered as the father of radiology. So it was an accidental invention when he was trying to investigate different types of vacuum tubes. So on the vacuum tube, there was an aluminum window kept on the vacuum tube. When he put on the vacuum tube, he found a shimmering effect on a board painted with the barium platinocyanide kept near to the vacuum tube. He found that this shimmering effect is because of some invisible rays which can penetrate through the harder substance. So that is how he come to know that there are some invisible rays which are penetrating the harder substances, and he named it as X-rays using the mathematical denomination of something unknown. So after inventing the X-ray, many companies has approached him saying that we'll give you this much amount of money if you give you the patent of his invention. But Röntgen, he was a nice person. He wanted the whole of the mankind to use his practical application of his invention. So he didn't give patent out of it. Neither he wanted that race to be named after him. But even though he refused to use the name Röntgen race, but still now X-rays are known as Röntgen race. So this is the first X-ray ever taken in the history. And the second X-ray, what you are seeing, this is the X-ray which he has taken to demonstrate it in a public function to show his invention. So after taking the X-ray, he was very much excited because the reason for the excitement is he could see the wedding ring of his wife Anna Berth Röntgen on the X-ray. The X-ray, first and second X-ray has been taken from his wife Anna Berth Röntgen. So after seeing this wedding ring, he became very much excited because he could see the wedding ring on his wife's hand. But that excitement didn't last long because she divorced him after a few months. So before venturing into the intricacies of such an intriguing subject of radiology, it should be worthwhile to understand the basics of spine radiology. So first thing is that before taking an X-ray, the X-ray film will be white in color. If you keep it on X-ray view boards, it appears transparent in color. When X-rays fall on the film, it darkens it. That's a very key concept of radiology. So I repeat, before taking an X-ray, the X-ray film is white or transparent in color. When X-rays fall on the film, it darkens it. This is a key concept of radiology. Next is basically there are 5 radiological densities exit. They are in the form of increasing density, air, fat, fluid, bone, and metal. These are the 5 densities where you can visualize on the X-ray. So now you can see a tumbler here. The one is this tumbler is filled with water, Tikthangirda, a piece of bone is immersed in, and a chavi or a key is been immersed in this, and X-ray has been taken. So now the first one, that is an air density. So the air density means the density will be very less. So more number of X-rays penetrates through the air. So it appears more black in color. So you can see the one is more black because that's an air density. Second is the Tikthangirda, which is a fat density. It allows little more X-rays, it's a little less X-rays to penetrate through that. So it appears little more white in color. And third is water. You can see more, little less X-rays penetrate through this, and it appears little more white, brighter in color. And the bone allows very less X-rays to penetrate, so it appears little more whiter. And the key does not allow in rays to penetrate, so it appears more brighter. So the different structures can be identified because of the difference in the densities these structures possesses. That's a very key concept of radiology. So I repeat. Basically, there are 5 radiological densities. They are in the order of increase in density, air, fat, fluid, bone, as well as metal. So this is how different structures can be identified. So now you can see a chest X-ray. In the chest X-ray, you can clearly see the lungs appears black in color because that is an air density. You can see the breast shadow here. You can clearly see the breast shadow here because that is a fat density. You can see the heart, which is more brighter because that's a fluid density because it is composed of blood. And you can see the ribs, which are much brighter, ribs as well as the scapula, which are much, clavicle also, it is much brighter because that's a bone density. It allows very less rays to penetrate through this. And you can see a septipin, which is a metal. It does not allow the X-rays to penetrate. So it appears much brighter. So the different structures in the body can be properly identified because in the difference in the densities, these structures process, and they are in the order of increasing brightness, air, fat, fluid, bone, and metal. So these are the radiological densities exist. And the different structures are identified based on these things. Next, 2 complications which we face whenever we get an X-ray in your hand. One is an underexposed X-rays, and second is an overexposed X-rays. The first is an underexposed X-rays. Underexposed means the technician who's taking, he has not put the proper exposure. or there's a problem with the machine. So less number of X-rays or very little X-rays has fallen on this film. So what has happened? It appears much brighter. So the borders are not distinct. The structures are not very clear. So we can't identify the structure properly if it is an underexposed. Overexposed means more X-rays has fallen on the film. So here you can see the air density as well as the fat density cannot be differentiated. The borders between the air and fat cannot be differentiated. Also, some part of the bone is also not visible. So the borders are not visible. The density of the structure is not properly seen. So we can't identify the different structures. So these are the two problems which we face in the clinic when we get an X-ray. One is an underexposed and second is the overexposed X-rays. If you get such X-rays in your clinic, what you have to do is that you need to send the patient back to the X-ray center saying that is not a properly exposed X-rays. You need to repeat the X-ray and get a properly exposed X-rays. That should be our aim. Next, the radiology of the cervical spine. So one basic thing in the X-rays, whenever you get an X-ray in your hand, make sure that the X-ray belongs to the same patient, because patient comes to our clinic with a bunch of X-rays. The X-ray may be his husband's or wife X-ray, his son's, daughters, etc. So whenever you get an X-ray in your hand, make sure that that X-ray belongs to the same patient. See the age of the patient, left and right. If OP number is there, see that also. So you may be a very good radiologist. You can diagnose your X-rays very properly. But making a proper diagnosis in a wrong patient is much embarrassing, and we can land up in trouble. So always the first thing is that whenever you get an X-ray, make sure that that X-ray belongs to the same patient. So next is the radiology of the cervical spine. So first of all, which view or has to be taken for a particular structure? For example, if you want to take an X-ray of the cervical spine, which view do you prefer? Whether it is an anterior posterior view or a posterior anterior view. So it depends upon the position of the structures or where the structure is located. So as far as a cervical spine is concerned, we need to take a posterior anterior view, because if you want to take an X-ray of the spine, we need to stand near to the film. So the vertebra is situated in the posterior aspect of the body. We need to take an anterior posterior X-ray. But if you want to take a chest X-ray, we need to take a posterior anterior view, because the heart as well as the big blood vessels lies anterior to the chest. So the structures, how much the structures near to the film, that much clarity, or it will not be magnified. The real image could be obtained if you take a X-ray which is very near to the film. So usually spine is taken. The spine is situated in the posterior aspect of the body, so it should be anterior posterior. But as far as the chest is concerned, we need to take a posterior anterior, because the heart as well as the big blood vessels lies anterior to the body. So this is how an anterior posterior chest X-ray is taken. Here the central beam is directed at the level of the thyroid cartilage at the C5 level. This is how an anterior posterior X-ray is taken. This is an anterior posterior X-ray. Second is the lateral projection. Here the lateral projection, the central beam will be directed just below the mastoid process at the level of the thyroid cartilage at the level of C5 vertebra. This is how a lateral projection X-ray is taken. This is a lateral X-ray. There's a Simmer's view. So normally, as you know, the cervical spine has got different movements in different magnitude and direction. So it is liable to many traumatic injuries. And one of the site which has most probable chance for a traumatic injury is the cervicothoracic junction. So normally in the lateral X-ray, when you take a X-ray, the shoulder shadow obscures the cervicothoracic junction. So in such condition, to get a clear view of the cervicothoracic junction, we need to get a Simmer's view. Here the hand will be abducted and the central beam is directed just above the shoulder. This is how the Simmer's view is taken. So this is a Simmer's view. Here you can see the C6, C7, T1, T2, etc. So if you want to get a proper relationship between the lower cervicothoracic junction, we need to go for a Simmer's view X-ray. Next is an oblique view X-ray. Suppose if a patient complains of pain in the neck radiating to hands, then the best preferred view is the oblique view, because oblique view clearly gives an idea about the vertebral foramen. So here this is an oblique view X-ray. The right oblique as well as left oblique is there. It is very similar to lateral view only. The central beam is directed at the level of C5 vertebra below the mass vertebra. It is obliquely situated. So this is an oblique view X-ray. Next is anterior posterior open mouth view. As far as this view is very important for Ayurvedic doctors, because usually in rheumatoid arthritis, the first and second cervical vertebra, that means the atlas and axis will be involved, and atlantoaxial dissociation is quite common in rheumatoid arthritis patient. Also in traumatic injuries, to study about the first and second cervical vertebra, we need to go for the anterior posterior open mouth projection. Here the mouth has to be properly open and the central beam is directed just below the incisor teeth. This is how an anterior posterior open mouth X-ray is taken. But one of the practical problems we face in the clinic is that by the time atlantoaxial dissociation has happened, the temporomandibular arthritis also will be set in, and patient will not be able to open the mouth completely, and it affects the precision of the diagnosis. This is how an anterior posterior open mouth projection has been taken. So this is an atlas, this is an axis. This is an anterior posterior open mouth view. This is the C2 vertebral body and dens or the odontoid process, and this is the C2 vertebral body. This is the lateral mass of C1. So here you can see this is a normal X-ray because the lateral border of C1 and C2 is the same line. Next view is the hyperflexion as well as the hyperextension views. Suppose if the patient is having a traumatic injury, what will happen? There will be a hyperflexion, there will be a soft tissue injury may happen. To see the stability of the soft tissue, we need to go for the hyperflexion as well as an hyperextension views. But if you want to do a hyperflexion or a hyperextension view, what we have to do is that the patient has to voluntarily move the neck, either flex or extend the neck, and we should not manually do that. Patient himself has to hyperflex or hyperextend the neck. So mainly to see the stability of the spine, whether the spine has got a proper stability, only soft tissue injury is there or not, we need to go for a hyperflexion as well as hyperextension view of the spine. Next is interpretation. So whenever you get an X-ray in your hand, we need to read it in terms of adequacy, alignment, bone, cartilage, disc, and soft tissue. But practically what is happening is that whenever you get an X-ray, cervical spine X-ray in your hand, we'll just see the bone as well as the disc space. These are the two things, and just we will land up in a diagnosis. That is not the proper way to diagnose an X-ray or interpret an X-ray. You need to interpret that in terms of adequacy, alignment, bone, cartilage, disc, and soft tissue. Then only you will be able to make a proper diagnosis. You will not miss any findings. So let us see what do you mean by adequacy. So as far as the cervical spine is concerned, if the film has to be adequate, it should contain all 7 cervical vertebrae. At the same time, cervicothoracic junction also should be visualized. And it should have a proper bony as well as soft tissue. Now you can see the bone tissue is proper density. You can see the soft tissue. You can see the trachea. It has got a proper density. So then we will call this an X-ray adequate because 7 cervical vertebrae and cervicothoracic junction is clearly visualized. Bone density is normal and soft tissue densities are normal. So we call it an adequate X-ray. This is an example of an inadequate X-ray. Here only 3 cervical vertebrae are seen. Here only 4 cervical vertebrae are seen. This is an inadequate X-ray because in this X-ray we cannot make a diagnosis, because usually if it is a dysplasia involved, usually it should be used to be C5, C6, and if it is a traumatic injury, it used to be the cervicothoracic junction. So nothing can be made out from this X-ray. So if you get an X-ray in your clinic like this, you need to send the patient back to the X-ray center saying that we need a properly exposed X-rays. It should not be inadequate. This is called as inadequate X-ray. This you can see it's an absolutely adequate X-ray, but here you can see it's an inadequate X-ray because the shoulder shadow obscures the cervical spine. In such condition, the X-ray technician can give some weight in the hand so that the shoulder will be depressed and they can take a proper X-ray. So if you get such X-ray in your hand from any X-ray clinic, send the patient back saying that we need a properly exposed X-rays. Next is an alignment. So whenever you get an X-ray in your hand, you should draw 4 imaginary lines. You should draw 4 imaginary lines. One is the anterior vertebral line. One is the anterior vertebral line in front of the vertebral body. That's the posterior vertebral line in the posterior border of the vertebral body. Next is the spinolaminar line in the posterior border of the spinal canal. And the spinous process line, that's in the tip of the spinous process. So you need to draw 4 imaginary lines. One is the anterior vertebral line. Repeat. One is the anterior vertebral line in front of the anterior border of the vertebral body. Posterior vertebral body in the posterior border of the vertebra. Spinolaminar line, the posterior border of the spinal canal, and the spinous process line. So among the 4 lines, the second line is the most reliable line because that is least disrupted by the osteophytes. So you get a clear alignment by looking into the second line, that's the posterior vertebral line. And the line should follow a smooth lordotic curve without any step off. So in this X-ray, if you draw this line, what you can see, you will get a step off. It is not a smooth alignment because there's a listhesis or a displacement of the bone. This is called as a malalignment. Usually, if we just see the X-ray, we may miss out the malalignment. But if you draw these 4 imaginary lines, we will get such a step off and we can diagnose listhesis properly. Next is the bony landmarks. So whenever you get an X-ray in your hand, your eye should follow the uninterrupted cortical border of each and every vertebral body. Your eye should follow uninterrupted cortical margin of each and every body. It should not, you will just look the whole of the spine once. No. Your eye should follow each border of all the vertebrae. Otherwise, if there is a small lytic or a destruction lesion in a vertebra, will be missed out. So this has to be our approach towards an X-ray. So the vertebral body should be rectangular in shape. All the cervical vertebrae will be rectangular in shape and roughly equal in shape. It is roughly equal in shape. It should be roughly equal, but the size of C3 and C4 will be the size of C4 and C5 will be slightly smaller than C3 and C6. That's the normal anatomy. Also, the anterior height, this is the anterior height, and the posterior height should be roughly equal. But here, if you see, you can come to know that the posterior height is slightly more. So 3 millimeter height will be more in the posterior aspect compared to the anterior aspect, and that is the normal anatomy of the cervical bone. Next, bony landmark. So in this bony landmark, we are seeing the vertebral bodies, the normal height and the normal anterior height and the posterior height and the shape of the vertebral body has been seen in this slide. And the next slide, we are going to see much more landmark. Next is the spinous process. The spinous process is situated in the posterior aspect of the vertebral body, and the size of the spinous process will be go on increasing as we come down. Next is a pedicle. This is a very, very important structure. When we read an X-ray, pedicles are very important structures because usually the osteolytic tumors and the infective lesions like port, spine, etc. usually first affects the pedicle. So pedicle is a very important structure. It connects the anterior part of the vertebrae to the posterior part of the vertebrae, or it supports the articular pillars, superior articulating process and the inferior articulating process being supported with the help of the pedicles. So it's a very important structure. Never ever miss this structure while reading an X-ray. And lamina is not distinctly seen on the X-ray. Next, the facetal joint. The superior articulating facet as well as the inferior articulating facet. So usually as we degenerate, there will be facetal hypertrophy will be there. Here you can see the facetal joint is normal. If it is thickly covered with the calcium, then it is very evident that facetal joint is hypertrophied. There can be a narrowing of the exit canal and patient can have a radiculopathy. So look into the facetal joints whenever you get an X-ray in your hand because facetal hypertrophy can be clearly seen on the X-ray. Next is the lateral mass. The lateral mass occurs as rhombo-shaped structure projecting downwards and backwards. This is the lateral mass. Next, the double cortical line. The double cortical line is not a structure because when you take an X-ray, instead of a pure lateral X-ray, it may have a slight upper or lower angulation. So because of the difference in the angulation, there occurs a double cortical line. These are not fracture, nothing. So these are the bony landmarks which you need to see whenever you get an X-ray in your hand. One is the vertebral body which you have seen in the last slide, the spinous process, pedicles, lamina, facetal joint, the lateral mass. These are the bony landmarks which you need to see whenever you get an X-ray in your hand. Next, the predental space. This under cartilaginous space, the space between the C2 vertebral body as well as the dens, that is called as the predental space, and the predental space should be 3 millimeter. Usually this is a predental space, it is 3 millimeters. If it is more than 3 millimeter, it indicates there is either there could be a fracture of the odontoid process of the dens or a disruption of the transverse ligament likely. So traumatic injuries, this predental space is very, very important. There's the disc space, you know, you are all masters in the disc space. The disc space should be, you should compare the disc space anteriorly and the posteriorly at all levels. It should be symmetric as we throughout. Normally this space, normal. If it is reduced, then we can come to know this space is reduced due to a degenerative disc disease. There's a soft tissue space. Usually, as I said, whenever you get an X-ray in your hand, we look into the bony structures only. We'll never look into the soft tissue structures. But in trauma, the soft tissue space is very important. Suppose a patient while carrying a weight on the head, if it falls, or if something falls on the head, we may suspect a fracture of the cervical spine. But when you take an X-ray, sometimes we cannot see any fracture line because there are many conditions where the fracture will be very subtle or occult, and we will miss when you see the X-ray. So in such condition, we have to go for the soft tissue shadows. So the nasopharyngeal space, that means in front of the C2 vertebral body. In front of the C1 vertebral body, that is the nasopharyngeal space. The nasopharyngeal space should be minimum 10 millimeter. Suppose if there is a small fracture at the C1, what will happen? The fracture leads to a hematoma, and usually the space will be increased. But the normal nasopharyngeal space is 10 millimeter. The retropharyngeal space, that means from C2 to C4, that is the retropharyngeal space, that should be 5 to 7 millimeter, and retrotracheal space should be 22 millimeter. Suppose if there is a subtle or occult fracture, what will happen? This soft tissue space will be much increased. It should be much increased, and that will prompt the physician to send for a CT scan to see whether there is a fracture or not. So in a very subtle or occult fracture, the soft tissue space is very important. First is the nasopharyngeal space in front of the C1 vertebral body, retropharyngeal space in front of C2 to C4, and the retrotracheal space from C5 to C7. These are the three soft tissue structures seen on the plain X-ray. So now you can see here you can see the retropharyngeal space should be 5 to 7 millimeter. But here you can see it is more than 20 or 25. So it is very evident that there could be a subtle fracture. If you observe here, you can see a subtle fracture here. But this soft tissue space which is increased gives us a clear indication that there is an occult or subtle fracture. So next is how to read an anterior posterior X-ray. Usually whenever you get an X-ray, anterior posterior cervical spine X-ray, how do you read an anterior posterior X-ray? So in the anterior posterior X-ray, we need to look into four things, only four things. One is the lateral mass. This is the lateral mass. And next is the spinous process. In the central part, what you can, this is the spinous process, this is the spinous process, and this is the spinous process, and this is the spinous process. And the vertebral body height and intervertebral disc space. So these are the four things which you need to see when you get an anterior posterior X-ray in your hand. So the lateral mass appears as an undulated margin. That means a smooth wave-like margin. So any fracture of the lateral mass can be seen on the this AP view X-ray. Second is the spinous process. This is the spinous process. This is the spinous process. This is the spinous process, and this is the spinous process. The spinous process should be in the midline. If the spinous process is right or left aligned, it indicates a dislocation of the vertebral body. Either it could be unilateral faceted dislocation, etc. And the interspinous distance, this interspinous distance should be symmetric. The spinous distance from C3 to C4 and C4 to C5 should be symmetrical. If it is increased 1.5 times more or less, it indicates a dislocation of the vertebral body. Then you have to see the vertebral body. If we suspect a compression fracture, the height of the vertebral body should be compared on both the sides. If there is a compression fracture, the height of the vertebral body will be reduced. Then the fourth, you need to look into the intervertebral disc space. In degenerative condition, in cervical spondylosis, etc., the disc space will be reduced. So to see the disc space, we have to go for the, you can look into the anterior posterior X-ray. So I repeat, in the anterior posterior X-ray, four things. One is the lateral mass. Second is the spinous process. Third is the vertebral body. And fourth is the intervertebral disc space. These are the four things which you need to see whenever you get an anterior posterior X-ray in your hand. Next is the lateral view X-ray. The lateral view X-ray gives the maximum information about the X-rays because you can see many structures starting from the occipital condyles to the vertebral bodies from C1 to C7 and T1. Intervertebral disc space can be seen. You can see the vertebral foramina. We can see the superior articulating facet and inferior articulating facet. You can see the lamina. You can see the spinous process. So maximum information about the cervical spine will be obtained in the lateral view. Here you can see the curvature is absolutely normal. All the vertebral bodies are seen. The vertebral disc space is normal. The intervertebral foramen is normal. The pedicles are intact. And lamina is clearly seen. And the spinous process is also seen. And the superior as well as the inferior articulating facet are clearly seen. So it gives the maximum information about the cervical spine. That is why we depend upon lateral view for the maximum information, especially if you suspect a spinal canal stenosis, if you suspect a intervertebral disc destruction, if you suspect a compression fracture, anything, we depend more upon the lateral view X-ray. Next is the oblique view. As I said, oblique view is much sensitive for assessing radiculopathy because in the oblique view, what you can see is that you can see intervertebral foramen clearly. The intervertebral foramen can be clearly seen on the oblique view X-ray. You can see the vertebral foramen is absolutely clean. Then vertebral body can be seen and pedicles. If you suspect a pedicular fracture, this oblique view X-ray is much superior than CT or MRI because pedicular fracture can be clearly seen in an oblique view X-ray. So pedicles and the if you suspect a fracture of the epiphyseal joints, if you suspect a fracture of the epiphyseal joint, that also can be seen on the oblique view X-rays. So, and also it is very sensitive for if a patient complains of pain in the neck radiating to hand, then the oblique view gives a maximum information. Next is the AP open mouth view or an odontoid view. So this is taken mainly in rheumatoid arthritis where atlantoaxial disassociation is suspected, or in cases where the patient attempts to hang, etc. Or if there is a trauma, if something falls on the head, usually the first vertebra which is affected is the C1 vertebra because it has got a very thin bony ring. So how to see whether the odontoid view is normal or not? So the lateral border of the C1 and the lateral border of the C2 should be in the same line. And the distance between the dens to the C1 should be symmetrical. So the distance from the dens to the medial border of the dens to the lateral border of the C1 should be symmetrical throughout. And the dens should have an uninterrupted cortical margin blended with that of the C2. This is not a very clear X-ray, but the dens and the C2 vertebral body should be normal. If you suspect a fracture of the dens, you can see a fracture line, and the distance between the dens and the C1 will not be symmetrical. So I'm not going to the trauma types because we have got only 1.5 hours. I'm just skipping. So this is an X-ray of an anterior posterior. I said normally the border of the C2 and the C1 should be in the same line. Here you can see the C1 is laterally displaced and the distance from the dens to the C1 is increased. So it's a fracture of the bony ring of C1. So this is important, this unilateral facetal dislocation. So if you draw an imaginary line, the posterior vertebral border, you can see there is a step off is there. You'll get a step off like this because there is a displacement of the vertebra. Normally, when you read a displacement, what you have to divide the vertebral body into 4 parts. First 25, second 25, third 25, and fourth. Here only, if it is less than 50% is displaced, we call it a unilateral facetal dislocation. It can happen from Ayurvedic doctors because normally in certain marma centers, etc., after the massage, what they will do is that they will just flex the neck and then laterally rotate the neck right to left. So when you do the lateral rotation in a flexed condition, what will happen? There can be a dislocation of the cervical vertebra. That is called as unilateral facetal dislocation. If less than 50% is displaced, we call it a unilateral facetal dislocation. It can happen from barbershop, hair cutting salons, where normally after the hair cutting, sometimes they may laterally bend the neck. That can lead to unilateral facetal dislocation. You have to offer some tips to the patient that to the hair cutter that if you don't do that, I'll give you some tips because it can sometimes lead to a unilateral facetal dislocation. Next, the bilateral facetal dislocation. Usually, this patient may not come to you because immediately the patient will be tetraplegic. So, more than 50% of the vertebrae slip to front, we call it a bilateral facetal dislocation. Next is the cervical kyphosis. Usually, patient with the pain in the cervical spine comes to you, and if you take an X-ray, so the second X-ray, what you're seeing, this is the normal X-ray because it has got a normal lordotic curve. There's a normal lordotic curve is there. But here, this is the pathology because the cervical spine is straightened. We call it a cervical kyphosis. As you know, normally the cervical spine has got a lordotic curve. The thoracic spine has got a kyphotic curve, and the lumbar spine has got a lordotic curve. Normally, because of the cervical muscle spasm, what will happen? The vertebrae may become straightened and leads to a condition called as cervical kyphosis. We also call it in a nickname military neck because the spine has become straightened. So it can happen, suppose if you have got a disc pathology, what will happen? There will be severe paraspinal muscle spasm will be there because the severe paraspinal muscle spasm, the neck may become straightened. Second, due to some trauma, suppose if there is a compression fracture, what will happen? The head will get tip forward and there can be a straightening of the spine. Third is a congenital condition. Sometimes a patient may born with a block vertebra. That means 2 or 3 vertebrae will be fused together. In such condition, also you will get a straight spine. Fourth is in pathological condition. If you have got a port spine or a osteolytic lesion, a part of the vertebra will be destroyed. What will happen? Or sometimes the disc may be collapsed, and because of the collapse of the disc, what will happen? The head will be tilted forward and push the neck backwards and causes a straightening of the spine. So this is called a cervical kyphosis. Normally, the best treatment for cervical kyphosis is that nadi sweda, because wet, moist heat is the best treatment for reducing the muscle spasm. So a nadi sweda is ideal to bring back the cervical spine to the normal position if it is only because of a cervical muscle spasm. Due to any anatomical defect like block vertebrae, osteolytic tumors, then compression fracture, etc., we can't say it. But if it is usually it is because of a disc pathology and due to a resultant reflex muscle spasm, it can be corrected with a simple nadi sweda. This is about the cervical kyphosis. Next is cervical spondylosis. As you know, aging is inevitable. And as a part of aging, the vertebra also undergoes degeneration. Here you can see, if you see this X-ray, this is a normal disc space, this is a normal disc space. But here when it comes to this side, the disc space is reduced. There's an osteophytic lipping, a beaking of the vertebra. And the anterior posterior length of the vertebra is increased. And the marginal sclerosis, the margin has become much white or dense. So it's very evident that there is a disc degeneration. Here also, the disc space is reduced, marginal sclerosis, osteophytic lipping. So this we will diagnose it as a case of a degeneration of the bone or a cervical spondylosis. Here also you can see there is a disc space has been reduced, osteophytic lipping is there. You can see there is a small depression on the vertebral end plate. That's a smallest node. So overall, this can lead to a diagnosis of cervical spondylosis, disc space reduction, marginal sclerosis, osteophytic lipping, and the normal, if you see, the instead of normal alignment is slightly lost. Instead of a smooth lordotic curve, the lordotic curve is slight step up. So all this we will diagnose as a case of cervical spondylosis. As far as the Ayurvedic treatment for cervical spondylosis is concerned, we do consider either the clinical manifestation will be either as a manyastamba or a vishwaji, but projecting a kapha-vata involvement. So in case of kapha-vata involvement, we need to look into the cervical spondylosis in different. One is a vata kaphahara chikitsa has to be done, but at the same time, shulahara chikitsa also has to be done. And as you know, the bone will be degenerated, so asthikshayajanya chikitsa has to be done. And sometimes due to the disc pathology or a bone pathology, it can compress the nerve, and it can, the nerve also will be in such condition. Nadi belya chikitsa also has to be considered. So depending upon the presentation, we need to do the treatment. But Vata Kafahara Chilsa and Shulahara Chilsa has to be a first line. So normally we need to go for a Snehana and Swedana. Usually I start with the Patra Potli Sweda. If there is too much of, if you see some armor reflex, etc., then I may go for the Chembira Pinda Sweda. But usually I start with the Patra Potli Sweda, which is Snehana, Swedana, and Shulahara. At the same time, we can go for the Sneha Basti also. Matra Basti with the Dhanvantara Thaila can be given because that is usually given in such a degenerative pathologies. Then Shira Basti. Shira Basti can be given. Gudujadi Shira Basti is found to be one of the best preparation because Tikta Shira is indicated in Astikshaya Vikara. So normally, Gudujadi Shira Basti can be given if you suspect a degenerative bony disease. And finally, Nasya can be given, any Brahmana Nasyas, Dhanvantara Taila, Karpasasya Taila, Kungumadi Taila, Shirabala Taila, etc. Any Nasya, because Nasya is indicating it to give strength to the Griva and Bahu, which has been told in Suswa Samhita. So Nasya also can be done. Normally in cervical spondylosis, I do adopt cervical traction also, because unlike in low back traction does not have much of the role, but cervical spine traction has got a very good role because it helps the posterior separation. So when you apply traction, then there can be a mild retraction of the disc is a possibility. So basically, there are three types of cervical traction is there. One is a continuous cervical traction where less weight is being put, either a 5 to 14 kgs of weight can be applied and is given continuously. When you can give up to 24 hours, that is called as continuous traction. Second is a static traction where the weight can be slightly increased. 7 to 14 kgs can be applied and it will be given for a limited period of time. I generally start with the half an hour of traction for half an hour traction twice or thrice in a day. And third is intermittent traction that is given with the help of a machine where there will be intermittently, there will be pull and release will be there. That in that tractive force can be given, much tractive force can be given to that patient. So these are the types of traction. Usually in cervical spondylosis, when radiculopathy is present, when the pain from the neck radiates into the hands, cervical traction gives a better result when given along with our Ayurvedic therapy. So that's about the treatment of cervical spondylosis. This is the rheumatoid spine. So as I told, the rheumatoid arthritis usually starts in the metacarpophalangeal joints or a proximal interphalangeal joints. But the rheumatoid arthritis starts at the cervical spine, mainly in the upper cervical spine, usually the atlas and axial region, in tandem with that of the proximal joint involvement. That means at the same time where the proximal joint is involved, the disease process starts at the upper cervical vertebra. So usually the upper cervical vertebra is much affected with the rheumatoid arthritis. So plain X-ray is an important tool in analyzing the structure of the bone. Here, if you see this X-ray, what you can see the C1 and C2 is completely fused. You can see almost there's an erosion of the bone and the borders are not distinct. Here also you can see the vertebral borders are not clear. The bone mineral density is completely lost. There's a gross demineralization. The disc is completely eroded and the end plates are also not distinct. So by seeing this X-ray, we can very well come to know that this is an inflammatory joint disorder, most probably a rheumatoid arthritis. In this X-ray also, you can see the C1 and C2 is completely fused. There is a gross demineralization of the C1 and C2. The vertebral alignment is completely lost. The disc space is completely eroded. These are certain areas of erosion. So this also again leads us to the diagnosis of any inflammatory arthritis, most probably rheumatoid arthritis. From the X-ray, we can't diagnose whether it is rheumatoid arthritis or not, but along with the history, laboratory investigations, etc., we can know whether it's a case of a rheumatoid arthritis or not. Usually the first and second cervical vertebra will be more affected with the rheumatoid arthritis. And the treatment should be, usually I start with a Dhanyamala or Agni Leba. Agni Leba, it has been practiced in my mother institution, where you can see 10 herbal drugs, the 5 dry drugs, 5 dry drugs and 5 wet drugs are being used. Among the wet drugs, 2 types of Actimanda, Premna perifolia and Premna sclerodendra serratum, then Nirgundi, Papata and Benda, and 5 dry drugs, Haridra, Sarshaba, Levanga, Marija, and Leshuna. It is been grinded and a paste is made and it is applied from the neck till the toe. And a small portion of it is applied on the vertex of the head. And it has been continued till the severe amata ama condition gets reduced. Along with that, we will do a dara with the Dhanyamala dara. This is a preparation which has been told Kerala textbooks and it is extensively practiced in Kerala. That is called as Dhanyamala, where a sour liquid is made out from these herbs. These herbs have been put in water, boil it, and after 10 to 15 days, the liquid becomes very sour, and that has been used for a dara. And this is a very miraculous preparation in Ama Samsrishta conditions, especially in Amavada, a miraculous preparation, and patient we get very good results if you do Dhanyamala dara in patients suffering from Ama Samsrishta disorders, especially Amavada. Then along with that, I do apply air and Mula Sharabasti. And if required, Valiga Sweda or Churna Pindasweda with the Kotanchukadi Churna. And these are my usual management in case of rheumatoid arthritis. Next is spinal canal stenosis. As I said in the previous X-ray, in the lateral view oblique view, you can clearly see the intervertebral foramina. But X-ray has got a very limited role in analyzing spinal canal stenosis. But here, if you see this X-ray, you can see the intervertebral foramina is narrowed. Definitely, we can assume that there could be a narrowing of the adjacent foramina, and patient will be having a severe radiculopathy, and the patient can be having a myelopathy. So, in this X-ray, we can clearly see the vertebral foramina is narrowed, and this is the facetal joints. There's a hypertrophy of the facetal joint is there. And these are normal vertebral foramina, but these are narrowed vertebral foramina. So in this condition, we can have an anuman, or we can infer that the patient will be having a narrowed vertebral foramina and narrowed exit foramina, and patient will be having signs and symptoms of either a central canal stenosis or an exit foraminal stenosis will be there. So usually patients with spinal canal stenosis, they will be having a tingling and numbness all along the body, especially with the hands and the lower limb. Patient may have a weakness of while walking. Patient can have heaviness of the body. Then the control of the micturition will be lost. These are the symptoms which a patient presents if the patient presents with the spinal canal stenosis. Normally, if it so this is how the canal gets stenosed. Disc osteophytes complex encroaching the spinal canal, and it compresses the spinal cord and leads to myelopathy. So normally, if you see the symptoms of spinal canal stenosis, it shows a kaphavrta vada. Avrta vada lakshanas are seen, mainly kaphavrta vada. In such condition, we need to do Tikshna and Rukshana Chikitsa has to be adopted initially. Usually, I start with a Vaidarna Basti, or you can use Sharabasi also. In North India, etc., it is more the Sharabasi which is more in use. We generally give here a Vaidarna Basti. And after the course of Vaidarna Basti, you should start with the either we can start with the Churna Pindasweda, or otherwise, you can, after a Vaidarna Basti is given, we can start with the Jambira Pindasweda, because Jambira Pindasweda is a Ruksha Snigdha Sweda. Initially, a Rukshna Chikitsa with Vaidarna Basti is done, or you can go for any Churna Pindasweda. Then later, in the second stage, you can go for a Jambira Pindasweda, which is a Ruksha Snigdha. So it can, Ruksha Snigdha Chikitsa is given, the patient generally gets much better. Then along with that, I generally go for this is the Vaidarna Basti. Then Jambira Pindasweda. And next I go for the Belamula Nirubasti. I prefer Belamula Nirubasti in all entrapment neuropathies, especially in spinal canal stenosis, because it contains Ashwagandha Churna as the Kalka. Because Ashwagandha Churna is very good for improving the neural plasticity. In spinal cord stenosis, what will happen? There can be myelopathy. So what will happen? Few neurons will be lost, and the nearby neurons has to take up the function of the lost neurons, and that phenomena is called as neural plasticity. So Ashwagandha is found to be a wonder drug to induce the neural plasticity. That's why I generally prefer Belamula Nirubasti in patients with the spinal canal stenosis. Along with that, orally also give Ashwagandha Ashta, Ashwagandha Churna, etc., because that's a wonder drug to induce the neural plasticity. So this is how I generally manage a case with the spinal canal stenosis. Next is the cervical rib. As you know, normally the rib starts from the first thoracic vertebra. In some cases, what will happen? A rib may start from the seventh cervical vertebra onwards. From seventh cervical vertebra, rib may start. That leads to a condition called as thoracic outlet syndrome. In thoracic outlet syndrome, what will happen is that the lower trunk of the brachial plexus as well as the subclavian artery will be compressed between the first rib as well as the scalenus muscle. Between the first rib and scalenus muscle, the lower trunk of the brachial plexus and the subclavian artery will be compressed. If the lower trunk of the brachial plexus is compressed, what it leads to neurological symptom. Patient may complain of pain in the hand. There will be atrophy of the muscles of the hypothenar muscles, and weakness of the hands will be there if there is a compression to the brachial plexus. If the subclavian artery is compressed, it leads to a claudicatory symptoms. That means the patient can have severe pain on activity. So to differentiate between if there is a claudicatory pain is not, what you have to do is that you have to do a test called the roots test. The roots test, the arm has to be continuously abducted and adducted for 2 minutes. So after some time, there will be severe pain, numbness and tingling sensation affects on the hands. And then it is diagnosed that there is a compression to the subclavian artery. So plain X-ray can detect a cervical rib, and a patient with a cervical rib usually have a condition called a thoracic outlet syndrome. So two structures are compressed. One is a nerve and second is an artery. Nerve can lead to severe pain in the shoulder, weakness of the inner muscles and weakness of the hand. And compression to subclavian artery can lead to symptoms called claudicatory symptoms and numbness, pain, hyperesthesia, etc. on movements. And we can, with the help of an Addison's test and the roots test, we can diagnose whether the patient is having a compression to subclavian artery or not. So this is how the cervical rib is diagnosed. This is also called a supernumerary rib or a neck rib. So am I going a little fast? Are you able to follow it properly?
Yes, yes.
Fine.
Yes, no problem.
No problem. Fine, sir. So next is the thoracic spine. As you know, the disease of the cervical spine, lumbar spine, and thoracic spine are almost normal, but there are a few notable differences are there. There are certain diseases which is more prone at thoracic area. That is, one is the compression fracture and osteolytic tumors. That means there is an affinity for the compression fracture. The lower thoracic T1, T11, T12 are the more are the areas which there is more prone to develop compression fracture. Also, osteolytic tumors and infective lesions like port spine, etc. There is a more affinity at this lower thoracic spine. But the disc bulge like neck and cervical spine and lumbar spine is very rare in thoracic spine because there's a proper buttressing by the rib cage. Because of the proper support by the rib cage, the disc bulge in thoracic spine is very less. But osteolytic tumors, compression fractures, and infective focus are more commonly seen in the thoracic spine. So this is how a anterior posterior thoracic spine X-ray is taken. Here the central beam is directed 2.5 centimeter below the sternal angle. This is how a anterior posterior cervical spine X-ray is taken. You can see in this anterior posterior, you can see the vertebral bodies, intervertebral disc space, you can see the pedicles, you can see the spinous process, you can see the ribs. So this much of information can be obtained from the anterior posterior X-ray of the cervical spine. And this is the lateral view. The lateral view you can give, suppose if you suspect a compression fracture, you can see in the lateral view clearly. You can see the vertebral body, intervertebral disc space. You can see the ribs. You can see the dome of the diaphragm. You can see the dome of the diaphragm. This much of information can be obtained with the help of the lateral view X-ray. So this is the compression fracture. Suppose if a patient above 70 years, if the patient comes to saying that I had just a fall on the ground hitting the buttock. Always in osteoporotic spine, a small fall, just on a fall on the floor, hitting the buttocks is enough to produce a compression fracture. If the patient complains of pain following a fall, you need to take an X-ray of the lower. Usually, the doctors will prescribe for a X-ray of the lumbar spine, lumbosacral spine, AP and lateral. No, it should never be a lumbosacral spine. It has to be thoracolumbar spine, AP and lateral, because the most common site for a compression fracture is the lower thoracic spine. So you can see this is an X-ray of a compression fracture. This is a normal vertebra. Here you can see the anterior height of the vertebra body is reduced. Here also you can see this is a wedge compression fracture of the vertebral body. This is another compression fracture. You can see there is an anterior height of the vertebra is reduced, this is a compression fracture. So thoracic spine is the area which is more subjected to the compression fracture. So always, I do repeat this, a takeaway message for you. Always, if a patient comes to your clinic with a fall hitting the back, always send the patient for a thoracolumbar X-ray, that too in a lateral view. It may represent a compression fracture. If there is no neurological involvement, you can easily treat the patient. You can advise the patient for 2 months of complete bed rest, and you can manage it by labor, etc. And with the medicines. If there is a neurological deficit, you need to send the patient to have an MRI and to a neurosurgeon if neurological intervention is required or not. If there's no neurological deficits, we can easily manage the patient. No need to refer the patient to any orthopedician, etc. This is the lumbar spine. Here you can see the height. The height is lesser than the horizontal diameter. Unlike the cervical spine, here the height is lesser than the horizontal diameter. That's a normal lumbar spine. And the disc space. These are the radiolucent horizontal shadows seen between the vertebral bodies. These are the normal radiolucent shadows seen between the vertebral bodies. There's an increase in the height as we come down. So the height of L2 and L3 will be more than L1 and L2. L3, L3 will be more than the L2, L3, and L4, L5 will be more than the L3, L4. Except in L5S1. Normally, the height of L5S1 will be little lesser than L4 and L5. That is the normal anatomy of the lumbar spine. Usually, whatever X-ray you get, you will see, go and see and say the L5S1 gap is reduced. No. L5S1 gap is slightly less than the L4, L5 or L3 and L4. But usually there's a progressive increase in height. This height is more than this height, and this height is more than this height. This height is more than this height, except at the L5S1. That's a normal anatomy of the lumbar spine. Here you can see the spinous process. The spinous process are seen as an oval-shaped shadows at the middle of the vertebral body. Next, the pedicles. Pedicles is a very important structure. You should never miss the pedicles. These are the oval-shaped shadows seen in both the sides of the vertebral body. Because pedicles, reading the pedicle in every X-ray is very important. Usually, osteolytic tumors, infection, etc. Destroys the pedicles first. The pedicles are not seen, then it is indicative that there's a big pathology going inside the vertebral body. And in the lateral view, it occurs as a rectangular in shape. This is the pedicle that occurs as a rectangular in shape. At the facetal joint, it's a linear oblique radiolucent shadows. You can see the linear oblique radiolucent shadows. And the pars interarticular is a very important structure because this is the one structure which connects the anterior part of the vertebrae to the posterior part. Usually, there can be a fracture of the pars interarticularis and it leads to a spondylolisthesis or a slippage of the vertebral body. So, this is an oblique X-ray of the lumbar spine. If you want to study about the pedicles, pars interarticularis, you need to take an X-ray called the oblique view X-ray of the spine. Here, can you see a dog? This is the ear of a dog. This is the mouth of the dog. This is the leg, and this is the body. So the neck part of the this dog is called a Scotty dog. So the neck part of this dog represents a pars interarticularis. Suppose if there's a fracture of the pars interarticularis, you can see a fracture line, or the neck will be absent in case of fracture of pars interarticularis. Second is the transverse process that is apparently seen on both the sides of the vertebra. Here you can see a smooth sclerotic, the articular surface usually occurs as a smooth sclerotic surface of the vertebral bodies, seen as a smooth sclerotic surface of the vertebral bodies. Next is gas shadows. It imitates as a osteolytic areas. Next is a condition called the Cupid's bow contour. Cupid's bow contour. Cupid's bow contour is not a pathology. Normally, as I said, the inferior end plate would be straight like this, the normal inferior end plate. But sometimes there can be normal variant. It's not a pathology. Some persons may have a normal variant. That is called as, that is non-flat surface of the inferior end plate. Sometimes it will not be flat like this. It will be non-flat inferior end plate. It resembles that of the upper limb of the double curve of the upper lip of human body, like a bow of the Roman god of erotic love. That is why it has got a name called a Cupid's bow contour. And it is not a pathology, it is a normal variant. Next is Soya's shadow. That's very important. So it is apparently seen on the both the sides of the vertebra. Soya shadow. Whenever you get a lumbar spine X-ray, you need to look into the Soya shadow, because suppose if a patient is having a abscess, a Soya's abscess or a tubercular infection of the upper spine, what will happen? The pus will drain into the Soya sheet and it obliterates or masks the Soya shadow. So sometimes to diagnose a existing abscess or infection at the upper level, if you take an X-ray, if Soya's shadow is absent, then we can we are for sure that there is some infective focus there up in the vertebra. Next is the pathological findings. So at the end of the class, there is a tutorial is there. So please make sure that you be very particular about the pathological findings. So in this X-ray, in the last X-ray I had shown you, there is a Soya's muscle shadow is there. Here in the left side, you can see a Soya's shadow. Here, can you see the Soya's shadow is obliterated because there could be some infection in the upper area and the pus is drained into the Soya sheet and masked it. Pus or sometimes a rupture of any organ, a abscess, drainage, etc. can lead to a masking of the Soya shadow. So always look into the Soya shadow. So in the coming X-rays in the tutorial, you will come to know what is the importance of absence of Soya's shadow. Next is the lumbosacralization. So normally, the transverse force of the L5 should be free like this. It should be free like this. But here you can see the transverse force is fused with that of the sacrum. This is called as lumbosacralization. So in, mainly 10 to 20% of the patients may be having a lumbosacralization will be there because the transverse forces will be fused with that of the sacrum. So here you can see this is the normal one. But here you can see the transverse force is widened and fused with that of the sacrum. So doctors are having different opinion whether lumbosacralization do cause back pain or not. But in my clinical practice, I feel that the lumbosacralization can do cause low back pain because usually if there is a lumbosacralization, the movement at the L5 will be reduced. So the more movement will be at L4, L5, and it can lead to an early degeneration of this disc. Also, the disc at this level will be very thin and it is more prone to early dispersion. So this is called as lumbosacralization. Next, the degenerative joint disorder. First is smallest node. So you can see there is a depression at the vertebral end plate. This is called a smallest node. This is a depression at the smaller. These two are X-rays and this is an MRI. So the definition of smaller nodes is that migration of the this material into the weakened part of the vertebral end plate. That means there is a protrusion of the this material into the weakened part of the vertebral end plate is called a smallest node. The smallest node can cause a pain because here you can see this material has entered into the vertebral body and contact with the bone marrow and produce an inflammation. Here you can see the white hyperintense lesion is indicative of an inflammatory response and patient can have pain because of this material gets contact with that of the bone marrow and produce an acute inflammation. This is one of smallest node. It can be better seen in the MRI rather than X-ray, but X-ray also usually visualizes smallest node. This is the lumbar spondylosis. You can see the huge osteophytic lipping, reduced disc space, sclerosis of the vertebral body. There is a sclerosis of the vertebral body. So this can be diagnosed as a case of lumbar spondylosis. Here is another X-ray. You can see there's a long osteophytic lipping. Actually, these osteophytic lippings are an adaptive process, or it is helping our body to prevent the disc from further slipping. So this is a long osteophytic lipping. Here also you can see there's a long osteophytic lipping. Here the disc space is reduced and there's a mild scoliosis. This X-ray also, if you see, the disc space collapse, there's a scoliosis at this level, osteophytic lipping, marginal sclerosis. All these lead to the diagnosis of a lumbar spondylosis. This is called a vacuum phenomenon. This is very important. This is a black shadow between the vertebral body, or a radiolucent shadow between the vertebral body, and that is called as vacuum phenomena. This vacuum phenomena is seen only in degenerative disc disease. Suppose if you don't see a black shadow here, I will send this patient for an MRI scan because I may suspect a sports pain or a degeneration or a erosion of the disc, and I may refer for a MRI scan. But this, after seeing this, I am very sure that this is a lumbar spondylosis because there is a vacuum phenomena. Vacuum phenomena is particularly seen only in case of degenerative joint disorder, especially degenerated disc. Here also again, that's a radiolucent shadow. So this is called as a vacuum phenomena. Vacuum phenomena is very specific for a degenerative joint disorder. There's a fish vertebra sign. So in case of gross lumbar spondylosis, on severe degeneration of the spine, what will happen? There will be a demineralization, or the bone mineral density will be reduced, and the vertebra will appear as a biconcave disc-based structure. It appears as a biconcave disc structure that is seen in osteoporotic spine. This is called as fish vertebra sign, and the fish has got a biconcave vertebral body. Next is empty box sign. Empty box sign, there's a reinforced peripheral trabecula with a loosened center. That means the periphery will be, the marginal sclerosis will be there with an empty central. That is called as empty box sign. That is seen in case of severe degeneration of the spine, or whenever there is a severe demineralization happen. This is called as empty box sign. Otherwise, usually there will be vertical as well as horizontal trabecula will be there. It appears white in color, but here it is central is black and only periphery is white in color. That is called as empty box sign. It indicates a gross demineralization or a degenerative pathology. Next, the verticalization of a trabecula. Usually, as I said, the bone will be having a vertical and horizontal trabecula will be there. But in degeneration of the spine, what will happen? There will be an accentuation of the horizontal trabecula. Here you can see the horizontal lines are completely absent. Only vertical lines will persist. This is called as verticalization of trabecula. It's also another feature of degeneration of the spine. Pain radiating in the lobe. A vasodilatation will be there. That means the blood vessels at the particular site of inflammation will be dilated. As a result, more blood will flow and it reduces the inflammation. At the same time, it washes away the inflammatory waste. And also normally in low back pain, the muscle spasm will be there. When the heat is applied to the particular area, what will happen? There will be muscle spasm will be relieved and the normal lordotic curve of the spine will be restored. So that is why usually start with cardio, because in acute phase, we are not supposed to move the back like severe massage or kiji. What will happen? Why? Because the nerve will be usually in a very compressed condition. So that time, a stable treatment without much movement, a kadibasti or a nadi shodha is ideally preferred initially. Along with that, I usually give matra basti with Tanundram Taila. Then, and as a Nitya Virajana, here in Kerala, we give Gandharvastadi Eranta Dailam, 30 ml of Gandharvastadi, 10 ml of Gandharvastadi Eranta Dailam with the 30 ml of Nirgundi Sorasa. So, in acute lumbago, Virajana with the Gandharvastadi Eranta Dailam and the 30 ml of Nirgundi Sorasa is found to be very effective. It is found in Chilsa, it is Chilsa Manjiri textbook, which is specific to Kerala. Then we can give Madhudailiga Basti, Dashmula Shira Basti, and Shashtiga Shali, Pindasweda. This is how I generally manage a patient with the lumbar spondylosis, either with a localized lumbago or with a sciatica syndrome. Normally, Kadivasti, sometimes I may, if the spasm is still there, I may go for a Patrabarla Pindasweda along with the Madhudailiga Basti or Dashmula Shira Basti, and finally I may end with the Shashtiga Shali Pindasweda. Usually, a 14 days of treatment will be fine with any sort of disc bulge, which causing an entrapment neuropathy, etc. Next is spinal canal stenosis. Usually, I said the X-ray has got a very limited role in spinal canal stenosis. But here, if you see this X-ray, what you can see, there's a osteophytes encroaching into the spinal canal. And the disc space is also reduced. So definitely the disc is protruded into this canal, and the bone also has been protruded. The osteophytic lipping is protruded. So definitely we can come to know that this patient will be having a spinal canal. So see this spinal canal. It's a very normal spinal canal. Here, the disc as well as the disc cannot be seen, but the osteophytic lipping is protruded into spinal canal, and this disc space is reduced. Definitely we can assume that the disc also has been bulged out and there's a osteophytic lipping. So this patient will be having a severe spinal canal stenosis. The treatment of spinal canal stenosis has been described in the same Kapha Avarta Chikitsa is generally done if the patient is having a spinal canal stenosis, which has been discussed in the cervical diseases. Next is an autoimmune disease. Suppose if a patient of 20 or 30, if a patient of 20 or 30 comes to saying that he is having a pain in the lower back, especially at the sacroiliac area, along with the oligoarthritis, that means lesser than 4 joints, along with back pain, 2 or 3 joints will be involved, like neck, ankle, etc. With the severe early morning stiffness, what will be your diagnosis? So normally it should be an ankylosing spondylitis, because it usually starts at the second or third decade of life, that means the 20s or 30s. Along with that, there will be severe low back pain, early morning stiffness, which lasts more than 1 hour, with the oligoarthritis. So if you're having a doubt about ankylosing spondylitis, then what you have to do is that you have to go for an X-ray of the sacroiliac joint. So there will be sacroiliitis will be there. That's the sacroiliitis is the cardinal sign of ankylosing spondylitis. Here you can see there is a marginal sclerosis of sacroiliac joint, and the cartilage space is widened. It is because of the inflammatory edema of the cartilage. So this is a typical sacroiliitis, a bilateral sacroiliitis. This is an initial X-ray. After some time, you can't see any joint margin, because the joint is completely, the cartilage is completely degenerated, and there is a fussiness of the joint margin. So the joint is completely destructed. So usually sacroiliitis will be first sign seen in case of ankylosing spondylitis. This little advanced phase of ankylosing spondylitis, there's a bridging between the vertebra. There's a bridging between the vertebra, and there is a calcification of the posterior elements. So this bridging, this is the deposition of the syndesmophytes that is seen in ankylosing spondylitis. Also, if you see, this vertebra has become squared, somewhat squared, not completely rectangular, it become almost squared, and there's a shiny corner. All the vertebral corners are shiny. This is called as a Romano sign, that is very typical of ankylosing spondylitis. Next is this is a full-blown ankylosing spondylitis. You can see a bamboo spine appearance will be there. All the vertebrae become a whole segment. So usually patient with the bamboo spine comes with a very stiff neck, and our therapist sometimes try to manipulate it by moving right or left. And if you move it like that, then it results in a condition called a chalk stick fracture, and you need to wire, etc. So never manipulate a patient with the ankylosing spondylitis too roughly. It can lead to a chalk stick fracture. This is a typical bamboo spine appearance seen in ankylosing spondylitis. This is another case that is a dagger sign. You can see that's a calcification of the supraspinous as well as the interspinous ligament. That's the central radio opacity. This is a dagger. It looks like a dagger or a knife. It's mainly because the calcification of the supraspinous as well as the interspinous ligament. And Trollick's tract sign, there are 3 lines will be there. The first 2 lines are mainly because of the calcification of the apophyseal joint, and the third line, the central line, is mainly because of the calcification of the supraspinous and interspinous ligament. This is called as Trollick tract sign. You can see 3 lines. This is also a hallmark of ankylosing spondylitis. Normally, ankylosing spondylitis will have the presentation of the Vata Rakta, but usually in during the practice, I used to do with the Patra Bodli Sweda, Jambira Pinda Sweda, etc. But when we give more of heat therapy, what will happen? More vasodilatation, more syndesmophytes will be deposited, and the long time, it's not good for the patient. Initially, during our treatment, patient may feel good, but after 1 week, patient may have exaggerated symptoms. So normally, I don't follow the typical textual line of treatment in ankylosing spondylitis. I usually start with a Legana Basti or any Ruksha Basti. Either you can give Legana Basti or any Ruksha Basti. Then I go for a Kaya Sega or Pirichil. Usually for the Pirichil, we give more temperature of oil up to 40, etc. But usually in ankylosing spondylitis, I start with a very lukewarm oil because more heat is not good for the ankylosing spondylitis, and do a Kaya Sega. But I generally advise the patient with the ankylosing spondylitis to come and take regular rubbing at least weekly once, because kyphotic, and also as soon as you diagnose a patient with the ankylosing spondylitis, advise them to lie down in the prone position, because forward bending is one of the most likely deformity which occurs to a patient with ankylosing. So advise them to lie down in the prone position. And if they don't know swimming, if possible, tell them to learn swimming and tell them to go for swimming. Swimming is the best exercise to prevent kyphotic deformity. At the same time, if you go for swimming, the anterior posterior movement of the rib cage will be normal, because costochondral calcification is another complication. So yoga and swimming is also an absolutely good therapy for ankylosing spondylitis. To reconfirm your radiological diagnosis, you can go for HLA-B27 blood test, human leukocytic antigen blood test, that will reconfirm your clinical as well as radiological diagnosis of an ankylosing spondylitis. Now, in this X-ray, you can see a severe projection of the osteophytes. It's not flowing down; it's projecting to the right. It is seen that osteophyte comes to you and say that I am having severe low back pain, especially in the night, with the recurrent urinary tract or respiratory infection and anemia. Then you have to always doubt about the possibility of a primary neoplasm of the bone, that is a multiple myeloma, because in Ayurveda, multiple myeloma cases comes regularly to Ayurvedic doctors. So, as I said, normally if a patient complains of severe low back pain, and it worsens in the night hours, especially in the early morning, accompanied with the anemia and recurrent infection, we have to suspect about the primary bony tumor, that is the multiple myeloma. So this is an X-ray of a multiple myeloma. Here you can see multiple collapse of the bone. This bone is collapsed, this bone is collapsed, this bone is collapsed, this is collapsed. So multiple collapse of the bone without any apparent disc space reduction. Disc space is maintained. And you can see area of lysis. You can see there's a bony destruction. These black shadows are indicative of a bony destruction. That is one of the hallmark of multiple myeloma. And also, if you, in this X-ray, you can see multiple collapse of the vertebra with the enlarged intervertebral foramen. Enlarged intervertebral foramen will be seen, and the disc space is maintained. There will be paraspinal soft tissue swelling. You know, any X-ray with the multiple myeloma, you can see enlarged paravertebral soft tissue swelling could be seen. Then this is a normal pedicle. Here the pedicle is lost. So pedicular destruction or missing owl sign or missing our own eye sign is seen in multiple myeloma. So that is why I said in any X-ray you need to look into the pedicle, because in pedicular destruction is quite common in tumor pathologies and in infective lesions. Always look into the pedicles whenever you get an X-ray in your hand. So this is another patient. This patient of 56, PJ Roy, is a patient of mine only. He came with the low back pain. He had an MRI which has been taken 2 years back, and the MRI shows that there's a disc bulge. I admitted the patient, but after 5 days of treatment, also the pain didn't get response. Then I took a blood test, and the ESR was very high. Then I took a repeat X-ray. Even though he had an MRI 2 years back, I took a repeated X-ray, and this X-ray shows, you see, there is a lytic lesions. Lytic lesions. So I had a doubt, and I sent for a serum protein electrophoresis, and he has been diagnosed to have a multiple myeloma. So since we could diagnose it at the early phase, we can treat it properly. But in this patient, I had a good expectation because we are diagnosed in a very early age phase, but patient responded well at the initial treatment, but later he had a second phase, and then recently he had a bone marrow transplant. Patient is fine now, but diagnosing at an early phase will help the patient much better. So if you after taking an X-ray of the spine, if you still have a doubt about a multiple myeloma, you have to take an X-ray of the skull. The skull shows a multiple punched out lesions. You can see light, or it is called a raindrop appearance or a moth-eaten pattern. This character feature is seen in multiple myeloma. This is an ivory vertebra. Ivory vertebra refers to the increased opacity of the bone without any change in the size and shape of the adjacent vertebra. So usually ivory vertebra is seen as a secondary to any tumor, metastatic lesions. Usually from prostate or from breast, etc. The patient will be having a white vertebra, usually metastatic lesion. This is a patient of this patient with the MRI. You can see there is a metastatic lesion, and this is a PET scan. PET scan shows a prostate and the deposit at the particular site. But this patient survived for 8 years, and he died of cardiac arrest, not because of this tumor pathology. Next, the infective spinal lesion. As you know, the tuberculosis of lungs has been reduced, or pulmonary tuberculosis has been reduced to a certain extent. But port spine is still rampant in our community. It's quite common in our community. Many a times we may not be able to diagnose port spine. But patient with the low back pain, whenever a patient with the low back pain comes to you, you need to check for a routine blood test. If the ESR is high, you need to always suspect about the possibility of a port spine or a tuberculosis of the spine. This is a patient with just 1 minute. My battery is getting low. I'll just charge my laptop. Sorry. So usually a patient with a port spine will have a low back pain, a focal vertebral pain. At a particular site, there will be severe pain. and it will not respond to any change in the position, and the pain will be worsened in the night. That will be the classical feature. If a sportsman patient may have a loss of appetite, weight loss, etc., but usually a focal vertebral pain without which does not relieve with the change in the position and worsen in the night hours. Here you can see this is an example of a sportsman. You can see destruction of the disc. There's a huge paravertebral soft tissue swelling, a huge paravertebral soft tissue swelling, and reduced vertebral height. Here is another case. You can see the disc has been completely destructed. Then the vertebral end plate is not seen. There is an erosion of the vertebral end plate. Here you can see there is a lytic lesion. The pedicles is absent. The disc is completely degenerated. This is a case of a port spine. The port spine is not treated in time. Suppose while doing a Panchakarma, if you are not diagnosed a port spine, what will happen? While doing a Abhinga, etc., there is a possibility that the vertebrae may become collapsed, and that leads to a severe angulation that is called as port spine gibbous. This is called as port spine gibbous. And the patient may lead to a ports paraplegia. Because the importance of investigation is many times I had seen few patients who are treated at Ayurveda hospital where they failed to diagnose it and done Abhinga, and finally the patient has landed up in ports paraplegia. This is called as gibbous, where you can see the protrusion from outside. There's a metabolic disorder of the spine. One is the Paget's disease. It's a metabolic disorder where the destruction of the bone and the deposition of the bone both will be increased. So the resorption and the deposit will be more increased, leads to a deformed and soft bones. This is called as Paget's disease. So another appearance is called as cotton wool appearance, because irregular destruction and deposition of the bone leads to, there will be an osteoclastic activity. That means the destruction of the bone and followed by osteoblastic activity, that deposit. So irregular deposits and destruction lead to appearance called the cotton wool appearance. This is a typical cotton wool appearance of the skull that you will get in if you take an X-ray. In Paget's disease, there will be a particular appearance of the spine will be there, that is called as picture frame appearance. There will be reinforced peripheral trabecula with a loosened center. It looks like a picture frame appearance. That's a very particular appearance of the Paget's disease of the spine. Okay. Gouty arthritis is very common nowadays in the present day clinical practice. Usually, if a patient says that I'm having pain all along the spine, when you press everywhere, if you feel tenderness, it is called as endosopathy, mainly because of the gouty reaction. So if there is a gouty reaction, you can give Mahamanjishtadi Kashaya, Kaishoragulu, which is a fine preparation. Advise them to reduce alcohol, red meat, non-veg, etc. Tell them to drink plenty of water. Along with that, if the pain is severe, you can go for Parisegam with the Dhanyamla, Dashamula. Sharabasti, Manjishtadi Sharabasti is also done. And if the patient is having severe burning sensation, then Shirabasti is also another treatment which is likely to done in case of gouty reaction. But if a patient presents with the tenderness all along the spine, especially young stage, you need to always think about the possibility of a gouty reaction, and uric acid level need to be checked, and treatment has to be initiated. Next is alkaptonuria. When you take an X-ray, if you find a calcified intervertebral disc, that is very particular of alkaptonuria. It's a metabolic disorder where there's a defect in the tyrosine metabolism, whereby there is a homogenetic acid oxidase enzyme will be absent, and it results in increased concentration of homogenetic acid in the body. And that leads to cartilage destruction and calcification. And this disease is also called as black urine disease, where the urine gets exposed to oxygen, becomes black, or if a ear wax exposed to air turns out to be very black. This is called as alkaptonuria. Nowadays, even we could see patients with the alkaptonuria, which will be having a severe cartilage damage at a very earlier onset. This is developmental disorders. As I said, spondylolysis, where there will be a fracture of the pars interarticular. I have shown you the pars interarticular X-ray before itself. So this is the normal Scotty dog. So this neck corresponds to the pars interarticularis. So in this X-ray, you can see the neck is absent. This is a case of a fracture of pars interarticularis. If there is a fracture of pars interarticularis, what will happen? There will be because the connection between the front and back will be lost and the vertebra will slip forward. That is called as spondylolisthesis. Here you can see if one part of vertebra is the vertebra has to be divided into 4 parts. If one part is slipped from, that is called as grade 1 spondylolisthesis. If 2 parts is slipped from, we call it a grade 2 spondylolisthesis. This is how spondylolisthesis is grade. Next is scoliosis, very important, especially if a young female at 11 years or 12 years comes to you and say that I am having a curve, you need to take an X-ray of the whole spine in the erect position. X-ray, whole spine X-ray with the pelvis in erect position. That should be your prescription. And there's an angle called Cobb's angle. If the Cobb's angle is more than 20, then it has to be surgically corrected. If it is less than 20, we can manage it conservatively in young patients. This is a degenerative scoliosis where the disc has been collapsed and result in a degenerative scoliosis. So young patient, that is called adult idiopathic scoliosis that need to be taken care. Cobb's angle has to be measured and the patient has to be, because before 16 years, the surgery has to be done. Otherwise, surgical correction will be very difficult and patient will end up in severe problems. Usually it's seen in 11 years, 12 years, 13, 14 years, etc. If you see a scoliosis, X-ray in erect position and the proper treatment has to be initiated. Next is spina bifida. So during the pregnancy time, if the mother does not take any folic acid, it can lead to a neural tube defect. Neural tube defect can lead to spina bifida occulta, spina bifida meningocele minor. The lesser variant is the spina bifida occulta. And this patient comes, if a patient comes with the low back pain, when you take an X-ray, if you see a slit in the spinous process, you can see the spinous process, there's a gap. This is called a spina bifida. Here also you can see this is a spinous, but it's not fused together. There's a gap between the spinous process. This is called as spina bifida occulta. In such patient, they'll be having a tuft of hair in the back and a fat pad below. This is called as spina bifida occulta. So here ends my topic of radiological diagnosis of spinal disorders, because we are going in, it takes actually minimum 3 hours to do, because it has to be slowly taught, and that too, rather than a online class. Offline classes would be more effective. Online classes may not be that effective for this condition. Then we'll be going for a tutorial for 5 minutes. So whatever who there may be a few students who are very inquisitive, who have learned, pick up something from my class. So by seeing these tutorials, you'll find, you'll understand what is the importance of reading the X-ray, how to read, etc. So I'll be asking some questions. You can unmute your mic and you can answer to the question. Is that okay?
Yes, sir. If anyone want to ask question, please raise your hand, so I will unmute you.
Fine. So this is a boy of 23-year-old came to me with the complaints of pain in the low back. So by seeing this X-ray, I have immediately sent this for an MRI scan. Can you say what are the findings in this X-ray? Can anyone answer? So this patient was admitted in allopathy hospital for 1 week. And after that, the pain did get reduced. And with the X-ray, he came to meet me. I said him, after seeing the X-ray, I said, immediately you need to get a MRI scan done. So what are the findings you could see in this X-ray? If the findings are right, wrong, etc., there's no problem. You can answer. Because it's an initial class, so any wrong answers are most acceptable.
Scoliosis. Scoliosis.
Okay, mild scoliosis that I do accept. Okay, but at what site, what area there's a scoliosis?
Thoracolumbar region, there is scoliosis.
Okay, there's
I
a
took
slight
thorax.
scoliosis there. Okay, I do accept. There is a minor scoliosis there. Then anyone else?
You can also write on chat box also.
Okay, in the chat box, I see the chat box also. If you can write, it's fine. But instead of that, I would appreciate. So by seeing this X-ray, you can see a lytic lesion here. I observe this lytic lesion. Here you can see a displace, here you can displace, but the displace is completely obliterated, and you can see a lytic lesion here. That's one finding. Second finding, you can see a soya shadow here. On the other side, can you see a soya shadow? This soya shadow is completely absent. And this is a rib. Here, can you see a rib? The risk has been completely eroded. This rib is not seen. Also here, there's a proper transverse process. Here, the transverse was eroded. So by seeing this lytic lesion, Neng boy, and the displace is completely destructed. One rib is not seen. Soya shadow is absent. I immediately send the patient for a MRI scan. MRI scan shows there is a port spine. There is a destruction of the disc. Prevertebral there's a soft tissues encroaching into the spinal canal. Here you can see that's a big soya sepsis, almost 300 to 400 ml of pus is present in this soya shadow. So I sent the patient to a neurosurgeon. He said that since the patient is having a severe infection, don't drain it. He has started with the AKT4 treatment, and the boy is absolutely fine. So without looking into this X-ray properly, if I had done an Abhinga, definitely this vertebra would have been collapsed and the patient would have been paraplegic for the life. So this is important why you should learn how to read an X-ray if you're treating a patient with the low back pain, etc. Otherwise, patient can fall up in POTS paraplegia. Is that clear? Can anyone say any finding from this X-ray? Nothing. It's a degenerate. Here you can see a fish vertebra sign because there's a gross demon. There's a concave vertebra. Then you can see a black shadow. This is called a vacuum phenomena, which is seen in degenerative joint disorder, osteophytic lipping. Here you can see an empty both sign because this is an empty both sign, and this is verticalization of the bacula. That's very indicative of a gross demyelinated spine with the curvature is lost. So it's a case of a lumbar spondylosis or a severe grossly degenerated spine. Can you say finding in this X-ray? Okay, there is an osteophytic lipping, a degenerative scoliosis, and this is a vacuum phenomena. This is again another case for a lumbar spondylosis. This X-ray. So normally, as I said, the rib should start from the thoracic spine, but here you can see a rib has been started from the cervical spine. This is called as cervical rib or a neck rib or a supernumerary rib. Can anyone say findings in this X-ray? Okay, Praveen Sharma has raised the hand. Please, sir, can you unmute them, sir?
So sacralization.
Hello.
Hello. Sacralization.
Which one?
Sacralization. Lumbar.
Okay, definitely
lumbar.
sacralization. I have to accept that. Beyond sacralization, there are another important finding, ma'am. Any other finding? There's a spina bifida here. You can see the spine is not completely fused. There is a gap here. This is a case of a spina bifida. Can anyone diagnose this? So the pathology is here at the lumbar spine. Can you diagnose what this disease is?
Osteolisthesis of vertebra L5S1.
L5S1. No. And here the pathology is in the thoracic spine. So this area, sir.
Okay.
What you said is right, sir. There's slight listhesis there. There's a grade 1 listhesis of this. L4 vertebra is there. Definitely, that's up. That's there, actually. But here, another important finding is there. Praveen Savanda's been. Tell me, ma'am.
Wedge compression,
No.
wedge compression fracture with lipping.
No. Not wedge compression fracture. So can I answer?
Raise your hand. Just raise your hand so I can unmute you.
Tuni Vyasas raise the hand, sir. Can I unmute Tuni, sir? Okay, so you can see a sharp osteopathic lippings project outwards at the thoracic spine and in the right hand side. What is the diagnosis? That is seen in diffuse idiopathic skeletal hyperostosis. This is a dish. You can see diffuse idiopathic skeletal hyperostosis at the thoracic spine. I told you in the thoracic spine, there is a sharp osteopathic lippings to one side, then that is indicative of a dish. So this X-ray, it's nothing but there is a osteophytes. This is not a dish because it's going upwards. It's a degenerated spine again. Can you diagnose this X-ray? This is X-ray of the thoracic spine, AP view. This patient is there now in my IPD undergoing a treatment. Look into the spine and can you diagnose? Okay, this is also another case of diffuse idiopathic skeletal hypertrophy because there's a sharp pointed osteophytes to the right side. On the left side, you can't see it. To the right side, sharp projecting osteophytes like this. It's a case of another case of diffuse idiopathic skeletal hyperostosis. You can see. It's a case of diffuse idiopathic skeletal hyperostosis. This is also an interesting X-ray. You may not answer this. Here, if you see this X-ray, don't look into this area. Here, actually, here, if you see the Sir, are you able to hear now, sir?
Yes, sir. Yes, sir.
In between. Sir, now, sir?
Presentation is not visible, sir.
Presentation is not visible. Now, sir?
Yes, sir. It is
Sir,
visible.
is it visible now?
Yes,
Eh?
sir.
Yes, visible.
Okay. Can you diagnose this X-ray, cervical spine X-ray? Here you can see
Severe
the
degenerative
bulk.
changes. No.
No, sir. Bulky osteophytes are seen in the anterior part of the vertebral body. This is a bulky osteophytes. These are seen in usually two conditions. One is in the dish and second is in the psoriatic arthritis. Psoriatic arthritis, there can be bulky osteophytes will be seen. But this is a case of a diffuse idiopathic skeletal hyperostosis. This has been reconfirmed with the thoracic anterior X-ray where there's a sharp projecting osteophytes are there. This is another case of degenerative spine. Can you diagnose this? Can you say the finding in this X-ray? Anyone? Pathology is in this vertebra. This is a case of a compression fracture. You can see there's a case of a compression fracture. This patient has got a fall and are sustained with a compression fracture. See the height? See the height? Here the height is reduced. This is a compression fracture. This case, this is also a case of a dish. This X-ray, can you diagnose what it could be? This is a case of idiopathic adolescent scoliosis. Case of idiopathic adolescent scoliosis. But the angle is lesser than 20. So we can manage the pace conservatively. We have to tell the patient to lie down into the side of the curve. Which is the concavity of the, to which side the spine is having a concave. That side the patient should be advised to lie down. And advise them to do proper exercise, calcium supplementation, vitamin D3, and our regular Ayurvedic treatments has to be carried out. This is a case of degenerative spine. You can see a vacuum phenomena, the marginal sclerosis, osteophytes, etc. Case of a degenerative spine. So thank you, one and all. I would like to thank my teacher, suspected Dr. Santosh Shawan sir, for this presentation. See, the problem with this online presentation that will be in the late evening. So after tedious OP from talking from morning to evening, at 7 o'clock may not be having that energy level. And also we are not seeing the students' face, etc., without any reaction. Just we are speaking. So I don't know how effectively students could follow this, but this could provide you a base for that to improve, to further improve. This may help. So if you have got any doubts or then you may reach me on drshibu.varghese@yahoo.com, or you can WhatsApp me any doubts 9946244088. And I thank all the organizers of this great organization for conducting such classes, and also especially for inviting me. Thank you one and all. If anyone has got any doubts, you are free to ask.
Thank you, Shubhu sir. If anyone want to ask question, please raise your hand. Yes, Dr. Supriya, you can ask your question. Dr. Supriya, unmute yourself and ask your question.
Hello.
Hello, tell me.
Namaste.
Tell me, Dr.
Sir,
Namaste,
yes, sir.
Supriya ji. Boliye.
yes, sir. Sir, which type of basti or any Panchakarma plans in case of partial sacralization of L5 vertebrae, sir?
See, for a partial sacralization, there is no need for any Panchakarma. But if the sacralization is leading to any pathology, suppose usually I said, usually patient with the lumbosacralization can have a bulged disc at L5S1, or since the vertebrae sacralize L4, L5, there will be hypermobilization will be there. If the disc is bulged and if it is causing a compression to sciatic nerve, our usual line of treatment for Gudrasi. Usually, if you ask me Basti, I would say it is the Erandamula Niruha Basti I do prefer, along with the Matra Basti with the Dhanvantara Taila. That is the Basti which I prefer. But if there is a severe compression, if there is a weakness of the legs, and if the reflexes are slightly sluggish, I may go for a Rajabana Basti. Otherwise, as I said, Matra Basti with the Erandamula Niruha Basti is the preferred Bastis at the initial set of the treatment.
Okay, sir. Thank you, sir.
Okay, is it clear, ma'am?
Yes, sir. Sure, sir. Thank you.
Okay, ma'am. I'd seen few chats in the chat box saying
Yes,
thanks,
Dr.
etc.
Harish, you can
Thank you.
ask.
Namaste, sir.
Namaste, Harish. Boliye, sir.
Sir, in condition of spine pathology associated with AMA, severe AMA, like
Okay.
10 years of history.
Okay.
So it is very difficult to give any type of sneha.
Fine.
So in such condition, even after starting with the Rukshana,
Okay.
patient is mildly responding, but still not able to give any Sandarpana. So in that condition, how to proceed?
See, as I said, the most important, because spinal disorders can be because of any reason. So
Yeah.
first thing is that we need to diagnose what exactly it is. As I said, usually if it is because of a rheumatoid arthritis, or if it is because of an ankylosing spondylitis, etc., patient will be having a ama samsrishta avastha will be there. But usually we need to start from Rukshana Chilsa to Snigdha Chilsa. In such condition, what I generally does is that we'll do for Rukshana Chilsa like Dhanyamladhara, certain labors, Shurna Pindasweda, Valiga Sweda, etc. initially. That's a pure Rukshana Chilsa. Then start slightly, then later on start with the Ruksha Snigdha Chilsa. That means Jambira Pindasweda can be administered. And finally, once the Amata has been reduced, you can gradually shift on to pure Snigdha Chilsa like Patra Podli Sweda, etc. So it has to be the step-by-step procedure, so that actually even though patient is having a Amatu at the early stage, gradually you can shift to the Snigdha Chikitsa, which will definitely help the patient. But usually, even though in as far as they would see here we get the patients for 7 to 14 days maximum. So even if it is because of a degenerative pathology, a disc bulge, even the mild AMA features are there also. Initially itself, if you start within spine disorders, I'm saying, particularly with the focal spinal disorder, if you start with the snigdha chilsa like Kadivasti or Patraparla, so the initial itself, that itself gives good result to the patient. There's no need for very particular following up of the textual books. If it is a focal, I repeat, if it is a focal amatwa is there, you may do that. Otherwise, Ruksha Chilsa, Ruksha Snigdha Julsa, and finally end up in Snigdha Chilsa. That's a protocol which we can effectively follow. Hope I'm
Thank
clear.
you. Yes, sir. Thank you.
Fine.
Hello.
Hello, yes, tell me.
Sir,
Tell me,
you
Vignesh ji.
suggested Lekhana Basti in ankylosing spondylosis case. That was
Yes.
your experience, sir.
Yes, see.
Yeah.
It's not a must that you should follow only Lekhana Basti. Any Rukshana Basti can be, any Tikshna Bastis can be given.
Okay.
It can be Shara Bastis, it can be thing. Lekhana Basti is one of the Rukshana Basti which I would suggest, Tikshna Basti which I would suggest.
So for how
Tell me.
many days or like what would be
If
the
it is a
treatment
Ruksha
period?
Basti, usually 3 only, a Yoga Basti procedure, that's all.
Okay, only for 8
Beyond
days.
that, I won't go for that. Then external
Depending
therapies
on
would
the...
prefer.
Okay. Thank you so much, sir.
Okay, sir.
Hello.
Hello, tell me, ma'am.
Yeah, this is Dr. Shubhangi. Thank you,
Okay.
sir, for a very elaborative and detailed lecture. Sir, मेरा
Okay,
एक प्रश्न था कि
nice to hear that.
yeah, nice. Sir, आप लेप चिकित्सा पे कुछ बोल सकते हैं? स्पाइनल कोई फ्रैक्चर है या इसमें? Have you tried some layers?
See, especially in case of compression fracture, etc., I do go for labor chilsas. But one problem because there's suppose I've seen in many hospitals where suppose if the patient is having an intervertebral disc collapse, they apply labor and make the patient to lie down. But one problem is that if you want to do labor, patient has to lie down in the prone position. When the patient lies down in the prone position, the spine will be in a more extensive state. But if there's a pathology pertaining to disc, etc., extension will again reduces the anterior posterior diameter of the spinal canal as well as the HF foramen, which worsens the symptom. So, usually in spine pathologies, keeping the patient in a prone position slightly exaggerates the pain. That is why I don't prefer long-term labor in spinal disorder. But if there is a compression fracture, etc., if it is producing too much of inflammation at that particular site, I may go for labor. Karthavatu labor. These are many. For compression fracture, there are a set of labums available. But I do prefer labum very limited. But Karthavatu labum is one labum which I generally prefer to do in spinal disorders. Because Karthavatu dries very fast. There's no need for the patient to lie down in the prone position for a long time. So, so that the hurdles of keeping the spine in the extended position can be overcome. At the same time, we'll get a result also.
Thank you, sir. Thank you.
Hello.
Hello.
Dr. Kendamit is asking about the pathophysiology of multiple myeloma, Ayurvedic and modern. The Dr. Kendamit is a renowned teaching faculty in Government Ayurved College, Bellary, Karnataka. And he's conducted so many...
Very privileged to answer that, sir. Sir, first of all, I would say, see, here in Kerala, etc., we do treat more number of patients with the low back pain. So more number of patients with the multiple myeloma initially come to Ayurvedic doctors. But one thing is that we usually, we don't use too much of these imaging tools like X-ray, MRI, or laboratory investigation. We miss such diagnosis. Any patient who gets admitted with a low back pain, I make it a point to do a blood routine investigation. So usually if a patient is having a multiple myeloma, the patient will be having a raised ESR, usually above 60 or 70 patient will be having a raised ESR. The patient with the low back pain who is having a raised ESR, I definitely doubt about the possibility of a multiple myeloma. In such condition, I usually go for an X-ray of the spine and X-ray of the skull to see whether there's any lytic lesions are available, or because multiple myeloma, in patients with the multiple myeloma, the pathophysiology, it affects the bone marrow. And as a result of bone marrow spreads to the bone, and it causes a lysis or a destruction of the bone. So if you take an X-ray, you can see the lytic lesion and multiple collapse of the vertebra, along with the puncture out lesion of the skull. After seeing that, if you're still having any doubt, the best investigation, you can go for a protein electrophoresis. Within one day, it costs around 1,000 to 1,200 rupees. There in a protein electrophoresis blood test, you can get an M band. If M band is seen, it is diagnostic of a multiple myeloma. If you still have any doubt, then you need to go for a bone marrow biopsy. But one urine test also you can do. There's a urine test called B.A.M.S protein test that will be positive in only up to 30% of cases. But in the X-ray, if you're having a doubt, you can send for a serum electrophoresis. At the same time, you can send the patient for an MRI. MRI, both in T1 as well as T2 sections, you can say hypointense lesion on the T1 and hyperintense lesion on the T2 could be seen. A multiple myeloma typical appearance can be seen in MRI. Because in X-ray, if you want to get a lytic lesion, there is more than 40% of the cancellous bone destruction has to happen. But MRI can pick up it at a very earlier phase. So raised ESR with old age, with a recurrent infection, anemia, and the pain is worsened in the night, then you need to definitely suspect about a multiple myeloma. Plain X-ray of the spine and a plain X-ray of any flat bone, either a skull or a hip bone has to be done. And if still having a doubt, you can send for a protein electrophoresis. Then we can diagnose the case. And as far as the Ayurvedic management is concerned, usually I don't manage patients with the multiple myeloma because nowadays the advent of new chemotherapy agents and is helping too much for the recovery of a multiple myeloma. So I usually send the patient for to the oncologist whom they can better manage a case with the multiple myeloma. So my job is to earlier diagnose the patient because this year itself we got diagnosed 4 cases of multiple myeloma, which among the 2 cases were very early onset, which the newer chemotherapy agents are helping very much, and the patients are absolutely fine now. The third patient, which I shown in the X-ray, even though we are diagnosed at a slightly earlier age, but the chemotherapy didn't act well. So
चेतन जी
Yes, sir. There might be some
आवाज आ रही
network
है? हैंग
problem.
हो रहा है.
सर डिस्कनेक्ट हो गए.
देखें एक बार जुड़े तो अपन इनको वोट ऑफ थैंक्स करके फिनिश
Yes,
करें.
yes.
अनिल शुक्ला जी जुड़े हैं क्या? इनवाइट कर दो. कम चिकित्सा का किस प्रकार मैनेजमेंट और कैसे कैसे होता है, बहुत निश्चित रूप से लाभदायक हुआ। हमारे जितने भी इसमें अटेंड करने वाले लोग थे, टीचर्स हैं, डॉक्टर्स हैं, पीजी स्टूडेंट, यूजी स्टूडेंट, सभी को निश्चित रूप से इसका बहुत लाभ प्राप्त होगा, बहुत ही फायदेमंद। हमारी जो केंद्रीय कार्यकारिणी के जितने भी हमारे पदाधिकारी हैं, जिनके निर्देशन में ये काम प्रारंभ हुआ है, हम सब 14 विषयों में ये प्रोग्राम कर रहे हैं, उन सब का भी बहुत बहुत धन्यवाद, आभार। हमारे साथी सह संयोजक संतोष चौबन जी, कोऑर्डिनेटर समन्वयक डॉक्टर चेतन जी, हमारे विश्व आयुर्वेद परिषद के संपर्क प्रमुख डॉक्टर अनिल शुक्ला जी, सभी का बहुत बहुत आभार, धन्यवाद, जिनके सहयोग से यह प्रोग्राम, यह कार्यक्रम संपन्न हुआ है। धन्यवाद। जय आयुर्वेद। शांति मंत्र और करें चेतन जी?
यस सर, यस सर।
हाँ, शांति मंत्र। सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु, मा कश्चित् दुःखभाग् भवेत्। ओम शांति शांति शांति। सभी को शुभ रात्रि।
थैंक यू सर, गुड नाइट ऑल।
बहुत अच्छा डॉक्टर चेतन, अच्छा प्रोग्राम हो गया। शुरुआत
Thank you,
अच्छी की आपने, करीब 100 तक संख्या पहुंच गई थी, 85+ तो मैंने